Welcome to the Professional Wonder Podcast. I am your host, Jonathan Conyers. I'm with my main man, Gabe.
How's it going?
I don't know. How was it? How was Puerto Rico?
Yeah, oh man, it was amazing. I don't even want to be here. Nah. Next time we got to do a podcast in Puerto Rico. We'll bring everyone.
We're gonna bring Dr. Angert with us. What's up, Dr. Angert? How you doing today?
I'm doing really well, thank you, John.
Dr. Angert is a neonatologist at NYU Langone Medical Center. A colleague of mine, a friend. Technically, are you my boss? Yeah, technically, right?
Not really. We work together. We're colleagues. We're co-workers.
It's his boss now.
So, Dr. Angert, what is a neonatologist?
That's a good question. I am a newborn intensive care doctor, and that means I take care of critically ill newborns. And so it's a highly specialized field within pediatrics. So that means that after medical school, you do a pediatrics residency, you finish that, and then you get further training just to take care of critically ill babies. And so you could imagine, we deal with babies and families at a really crucial point in their lives where, there's a lot of emotion and a lot of, trauma and a lot of things built into that time period. So, but there's a lot of beauty and grace and a lot of things to make you feel good about too.
Yeah,
so
it sounds beautiful and very scary at the same time. Yeah,
that is a good way to look at it. I do think that's true. And the one thing that I would say to that is that the training that you get is really long. Like, it's not like you show up and like a week later they're like, okay, you're off on your own. And we can get into that, but like you really go through a lot of training and steps where you get more and more responsibility and autonomy as you learn more. So you're like, okay, I'm comfortable with this, on to the next step. But you're not like already in charge on day one. There's like so many steps that you get to that level of comfort in like a slow graduated fashion over 10 years. A long time. A lot of training, but it's an important job. So
thank you. Got to do it. So let's take it back. So usually we like to start off with, what was your childhood like? What was your first interest that sparked you into medicine? And take us on the path and let the people know what it takes to be a neonatologist.
All right. Well, I grew up in Chicago. I was born in the city limits, within the city of Chicago, and then my family moved to the suburbs. And I would say the first memories I have of really wanting to be a doctor were when I was sitting at the foot of my parents' bed, and they had a TV, and they were watching some of those old shows. I remember Emergency. That was when I really loved Trapper John, MD, and then MASH. Like, those are all the old 70s shows, and I was a kid of the 70s. So some of those are like a little more adult for like the age I was, but my dad would like let me sit there and just kind of watch. And they had I just thought I really looked up to the physicians, and I thought that the work that they did seemed really important and valuable, and something that I would myself really be interested in doing. But it also seemed really daunting because we did have relatives that I didn't know who were physicians, but there was no one else in my immediate family who was a doctor. So I didn't have any direct role models. There's only people I had heard about. But somehow I was like, well, maybe I can do that, so that was what kind of first, I think, sparked my interest in medicine. But as I said, it's a really long road.
Wow. Okay, you said you watched doctor shows as well. Yeah. Do you also watch Grey's Anatomy?
I watch it for a little bit. It was a little bit too much like a soap opera. And then I'll tell you, it's okay, what was the big show with Noah Weil? ER? That was the ER. Yeah. So I was the same stage and training as Noah Weil was in that show. And so we used to watch it in medical school. I was first year med student. He's a first year med student. And we were all the med students would watch ER together. And then I was like, this is really stressful. It feels like work. Because I'm like, what's the differential diagnosis? What would I do next? And then I was like, oh, I didn't think of that. Oh man, am I not a good doctor? And I'm like, wait a second. They have writers. Yeah. And that's a script. So I did appreciate it, and some of the parts were realistic and some were really not. But I did find it very stressful to watch something that was a little too close to what I did every day. So I still do like some medical dramas. The one that I think actually is probably my favorite, and surprisingly is probably the most true, is Scrubs. That show
that's
is
gross.
real.
Yeah, that's.
I mean, they're making fun of it, but
Yeah.
the things they're making fun of, you're like,
Yeah,
that
that's true.
happens. That happens.
Does it ever bother you when you watch it? Like when I watch a medical show and they literally like are doing something wrong or something is set up completely wrong. Does it bother you a little bit?
Yeah, it does. I'm like, they usually have like one person who does too much.
Yeah.
I'm like, you're the neurosurgeon and the obstetrician? Really? Like, how is that? That's not the way it works at all. Like, and then I find like they really mess with time. Like things, because they, so many times, like 30 minutes hour show, and you're like, there's no way that happens that fast.
Yeah. It can happen over a long period of time.
Yeah.
College, med school. Let's keep going into it.
Let's keep going. Sure. So I ended up going to Brandeis. I applied to a bunch of schools in the Midwest because I was from Chicago. And then the only school I applied to in the East Coast was Brandeis. And I got in and I was like, sure, I'll leave my hometown. And it felt like a different era because I had never been to the East Coast, never been to Boston or New York or anywhere. But I was like, it's a good school. They accepted me. I got some scholarship money. I'm like, I'm gonna do that. And so literally the first time I had ever seen or stepped foot on the campus or even seen Boston was the day I showed up for my first day of college.
Wow.
Which kind of felt crazy because, now everyone does video tours. People go on college tours. They drive around. They look at it. They talk, and I was like, yeah, I'll go there. And I was so lucky because it's a great school. They have a really really well put together pre-med program. So if you want to do medicine, they really know how to like guide you and to like help you along, and they do kind of weed you out. Like if you're not doing well, they're like, you maybe should think of another career. But so I learned that I just had to work incredibly hard. Like that was the lesson. Like I was like, oh, high school, I worked hard, but I didn't, it wasn't like I was like studying all the time, and then in college, I realized that like I'd have to commit way, way, way more time than I had ever imagined to studying because there's just no way to learn all the material you need in order to be successful. And so I learned it the hard way. Like I did terrible on my first chemistry test. And I was like, what? Wait, I'm not used to doing this badly. Like usually I just do what I do and I do fine. It's all right. And I was like, oh, I really get it. I get it. Like it was like a moment.
Gotta put the work in.
Yeah.
Especially you're going to be taking care of babies.
Yeah, for sure. Yeah. So that was college. Like that, like learning that you're just going to have to like devote a lot of time. And I had my fun too. Like I was like studying for the tests. And then when tests are done, hang out with your friends. I disappear. Like people are like, where's Rob? Like midterms, like he's not there.
Did you go straight into medical school or was it a non-traditional route, maybe work first, or how was that process?
I zoomed straight in. I didn't take a day off. I was like, I graduated from college and then I went directly to med school without a day off. I felt like I had momentum. I'm a little young anyway, like I'm a December birthday. So I was 21 when I graduated college and started medical school, like a little,
nice. Not
quite Doogie Howser territory, but I was young. And, it was hard because again, it's like stepping it up a level. Like I thought I was working hard in college. And then I go to medical school and it's like the same kind of, realization. You're like, oh, that's not going to cut it. What you did in college, what you thought was working hard, isn't even close to what you're going to need to work hard to do to be successful in medical school. So it was like a whole new level of like effort and time and dedication and devotion. And so that was really an intense period, especially the first 2 years. There's like, you have to learn anatomy and pharmacology and pathology. Like these topics are like huge and you just have to like put a lot in your brain. Yeah. So it was tough. But I was lucky enough to go. I went to the University of Kentucky for med school. That's where my mom, most of her life, she was raised. And then, so I was an in-state resident when I was applying to medical school. And I really, really loved New York after being in Boston. And I wanted to go to New York for med school. And so I was like, okay, I'll just, I'll apply in New York, and then I've got state schools because that's my home state. So I applied, and they interviewed me right away, and they have this rolling admission thing. They like interview on a Tuesday, and Friday they offer you a position if they're gonna or not. And I get home from my trip for my interview, and my friends like they had gotten the phone call and they like threw me a party like, you're into med school, and I had to decide pretty quickly if I was going to go there or not, but they gave me like a scholarship.
Wow.
My mom lived there. My grandparents all lived there. And I was like, I guess New York's going to have to wait. Like that's just going to have to wait.
Somehow you ended up here though.
Yes, that's its own story.
We got time.
How much school did you go through before you were like, finally, I'm done?
So there's 4 years of college, and then it's 4 years of medical school, which I did in Kentucky. And then you do postgraduate training, 3 years of pediatrics training, which I did in Boston at Tufts. And then I did another 3 years of newborn intensive care training, also at Tufts. So after the 4 years of college, it's an additional 10 years. So it's 14 years after high school.
Wow.
When did you decide? But when did you decide that you wanted to work with babies?
So I knew in medical school I was going to do pediatrics. I love pediatrics. I loved working with kids. I love the type of medicine. I love the dynamics of working with families. But I wasn't necessarily dedicated to newborns because I didn't have any experience. And then when I went to my pediatrics training, they just have an amazing NICU at the place I trained. As we do at NYU as well, I have to say. But where I trained, they have an incredible NICU with a great group of doctors. And after I got over my shock of being there, because the NICU is like a really different place and very challenging. So once I got like settled and figured out how to do a few things, I really just fell in love with the medicine, with all of the different aspects of the field. And it's just something that like, I was like, oh, it felt like it fit. I was like, I want to do this, like this is the thing I want to do with my life professionally. So that's how I ended up doing it. And I loved the NICU so much where I stayed there for my training. Like I applied all over, but I was like, I really want to stay here because this is the place, this is the kind of medicine I want to do. I want to be trained by these people. So I was really happy, lucky to be there.
You don't find working with babies to be like scary at all?
It is. Like I think that like I try to kind of keep it in perspective. And sometimes, there are moments where you're like, I'm not sure what's going on here. There's uncertainty. I always fall back on like, I'm trained to deal with this, like this is what I've done for like 10 or 14 years. I've been doing this. And then another like add on another 19 years of practice. Like I've been doing, I graduated a long time ago too. I'm not that young. So, but not only that, but I also have learned to be humble, right? Like I don't know everything. There are things that I've never seen before or things that I don't recognize. And I'm lucky enough to have really smart colleagues and friends. And so when that happens, like I will like take a step back, think things through, call a friend, call a colleague, ask for help. I'm not afraid to do that. And I think that like makes me in some ways a better doctor because you're not just limited to what's in my brain and like what my thoughts are. I also feel like, you can have the benefit of everyone at our institution, my other friends from elsewhere who I might call for like a little question. And I think that helps allay the fear. There are just sometimes, you got to live with it. You're like, it's scary. You're in charge of the team. And you're going to have to like get everything from point A to point B. And you have to like take a step back, calm your nerves, like try not to like let emotions drive your decisions, and try to like make a good plan and help the baby and help the family. Like that's my approach to getting through it.
I think and personal because we work side by side. I think one of the best things that a lot of people probably have, like doctors have this complex where they know it all and things like that. And I promise you, it's really a joy working with you. At the end of the day, you are a leader, right? If there's a cold, if there's a really bad situation, you got to have the last answer. Even if you're like, all right, it's respiratory, John, what we're doing, or you want to rely on a nurse, or you're giving people their roles and you're allowing us to work on what we're experts at. At the end of the day, it still falls on your shoulders. So it's very true. Like the fact that you're always open to talking, open into listening. Even if you're trained, I know a lot of your job is, program director, training fellows, training residents, training the next line of doctors. Even, plenty of times you'll grab me and say, can you train him on a ventilator? This is your expertise. Even though I'm a doctor, this is what you do. And I think for, to make people feel good, is very reassuring, and it creates a certain type of atmosphere that is very conducive to what we do. And with you personally, I always see a lot of passion. I know you're always focusing on the family. You're always trying to involve the parents, which is very important in our job. I think a lot of people don't realize that's half our battle, because
Absolutely.
we're dealing with parents and mothers who are going through a lot and fathers who are going through a lot. And it's not just from a clinical standpoint, it's how do we calm them down and how do we gain their trust, which is not always easy to do. So I'm saying all that to say, like, where do you get that passion from? Like, why are you so into, because a lot of times I was like, I'm the doctor, like, sit down, like, let me do my job. But you're always so concerned about how the family feel and bringing them into what's going on.
Well, yeah, thank you for asking that question. I kind of bring it back to my own experience that I don't really talk about a lot, but I think this is a good forum to bring it up. I had my own experience in the NICU from the other side, so NICU parent. And my wife and I had a baby right at the end of my fellowship training. And the baby was born early and extremely ill, very unexpectedly, and only lived a day. And that was such a powerful experience to be a neonatologist, to be at the peak. I'm finishing my training. I'm like literally a little more than a month away from being an attending physician. Like I've done all the training, and I'm totally helpless. Like there was literally nothing I could do for my own child. I mean, it was like such a hard experience to live through. And for it to happen in the ICU where I had spent almost 6 years with people who I loved, they were like family. It was really hard. And I think the thing that got my wife and I through it was that our family came and friends from far and wide. Like so many people, everyone just came. They were like, what do you need? We want to be with you. We love you. We're here for you. And, we were like in total shock, completely traumatized, living through this experience where, this is my world, my life. I've spent all these years learning to do this, and there's nothing I can do. Like it was just a hopeless situation. But we were supported by all of our loved ones, and they were there for us in a way that made it, like, it brought us as a couple together. It helped us process the experience of having this baby who didn't live, and it really, I think, formed me as a physician in some ways, because it seared in my mind this perspective about what it's like to be on the other side. Like, you can imagine or empathize or think about like what somebody else might feel. But at least for me in that experience, I knew what it felt like. And I look at parents and I see them sometimes and they're like alone and terrified, and they don't even have the benefit of all the knowledge that I had. I mean, maybe it worked against me too, because I knew the good and the bad, but they didn't have any of that. Or maybe they do have some knowledge, but they're in this moment, and I identify with that in a way, with like the right amount of professional distance. I'm not like, I know your experience isn't necessarily mine, but it makes me really want to make that experience tolerable and to try to make it better and to try to have some way to like let people bond with their babies, let them understand, let them accept whatever the new reality is. If there's something we can fix, great, we're going to fix that. If there's something we can't fix, we got to live with this. Let's figure out how. Those are the things that I think were really formative to me. And I think that kind of experience made me who I am in terms of like what kind of doctor I strive to be. I don't know if I always achieve that, but I try.
So in the case where you have to deal with someone else going through that situation, how would you deliver that? How do you talk to those families?
Yeah, that's a really, really good question. There actually is a lot of literature, and people have studied that in terms of like how to best do that. A lot of it comes from cancer literature. They break a lot of bad news to cancer patients. It's like every day they're like, someone comes into their office with cancer and they're going to tell them, So they've actually looked at that. And so we incorporate all of that, and then we adapt it to the neonates, and other people have kind of looked at that and studied that. And there's like a whole science to how you can really there are like steps you take. We have a whole curriculum that we teach our fellows and that we use ourselves in order to kind of set the stage and make the environment correct, and allow the parents as much control as they can have. They need to have. Like, you give them, can I tell you about this? Do you want to hear more about that? Like, and all these different steps we have that help really deliver the news in a way that like minimizes the trauma, but respects the parents and gives them some autonomy and control over how and when and how much they hear the information. And then we give them like a follow-up plan, like here's what's going to happen next, right? Like here's what we have. Maybe you need some time to process that. I'll check in with you in an hour, or we're going to do this and this and this, or here's my card. If you may have questions before the next time we talk, just call. Like some kind of way to close the loop, so they have a way to like they're not just like left floating with that bad information. And I personally, I hate like I make people cry sometimes. Like I walk into their room and I tell them something that's gonna like make them cry. So, and I don't have like 3 hours to sit with a crying patient because I may have 40 or 50 more patients who need my attention. So I try to spend as much time as I can, go through that process, and then I try to get support. The hospital has built-in support. There are social workers. That patient has a nurse that they've known for maybe up to 12 hours, or they had the shift before. Someone they know, get the social worker, get other people. Do you have a family member we can call? Sometimes if you can bring that person in ahead of time, like to get them that support that I had, right? Like I had all that support that came to help me, to make me feel good. I want to make sure that I don't leave somebody in that state. Like if you walk out of the room and somebody's crying alone, that's like, I feel like that's like almost like a crime. They're like, you didn't give them, and you didn't finish your job. Like that person is upset and you just walked away. Yeah. Like, I mean, like I said, I can't spend the rest of the night with them and comfort them, but like find someone who can, get a plan, get someone, those are the kinds of things that I think make living with whatever bad news I'm having to share a little better.
Yeah, and I to go back, as you know, like I know a lot of times, like a lot of doctors may ask me to speak to a lot of parents because I've had NICU experience also with my daughter and being there for months. But like you kind of said, no matter what you've been through, when that person is going through that situation, no matter, you could comfort them for a minute, but they're still watching their child, in a way suffer, right? Yeah. But to stay on this topic, one of the things that, I admire from not just you, but a lot of the doctors on our team is like this ability to like deliver these bad news, and something we call family meetings. So usually when we say it's a family meeting, we're huddling like, oh man, because that's when you're delivering to the family maybe some unfortunate news most of the time, or we want to trach, or we need to do this, or it may not look appealing, but this can extend the baby's life, or all of these situations. But to be able to constantly, because as our leader, you have to focus on our well-being also, right? How does Jonathan feel? How does this person feel? Are you okay? And then you're constantly probably in the middle of the heat, right? Because most of the time they're not going to blame me. They're going to be like, where's Dr. Angert? Where's the doctor, Yeah. So how is it like taking care of your mental health, where you're constantly, like who's checking up on you? You're delivering the bad news. Even if it don't have nothing to really do to you, or it's something that's totally out of your control, you have to take the heat, and you have to check up on 80 people, teach fellows. Like, how do you guys keep smiles on your face, and what are some of the things you do to de-stress? What would you tell doctors?
Well, I think everybody, has their own strategies that they've devised. And I think med schools and residency programs do try to teach that as part of the curriculum. Like a big buzzword is wellness. Like, what's your wellness plan? Like, what do you do for that? And so there are a lot of like events and things and like ways that other people, that we try to like teach young doctors how to do that. But at the end of the day, you have to figure out what works for you. Right. And like what suits you. Like for some people it's doing yoga, for, whatever. For me, I find, physical activity is really important. Like I find that I just started getting up. I have my wife to thank for this. Like she started ahead of me, but getting up in the morning and just getting exercise before work. Like it sounds simple, but like I get up every day an hour or more before I need to. And I either go to the gym, I go for a run. I have an indoor bike that I ride. It's not a Peloton. It's like an old bike on a trainer. It's not fancy. Like an iPad, that's fancy. So, but I just do I feel like, okay, there's one thing I can control. Like I've done one good thing that's healthy, it's good for me, and like I like feeling fit. And so that's like one thing that nobody can take away. Like no experience throughout the day, however good or bad, is going to change the fact that I can say to myself, I got some exercise. So that's one thing. The other things I think are like the support of the family and friends that I told you about is really, really important to me. I have like really cherished and loved old friends. like I have friends from like 30, 40 years ago. My wife, I've known her since we were 17, 18 years old. And like, you know, forever. And then my newest friend is like, you know, like 10 years old, or maybe 1 year, because John's my buddy. So he's in the, okay, we got to age a little bit together here, buddy. But no, really. And so people who know you really well, I think, can understand and listen, have the patience to listen.
Yeah.
And so, you know, I have like I don't have a million friends, but I have a good group of old core friends who really I find are very supportive, who I can talk about with, you know, I can talk about real things with them. You know, it's not just like the sports scores. It's like real stuff that happened in my life or that's going on that I want to process. And I listen to them. And I find that, you know, and my family too, like, you know, beloved family members. My wife's family is really big. And, you know, my own family, I are really key and important. My mom, my sister, you know, really being able to have people that you can be real with, I find is really helpful. But also, I mean, I do feel like part of our job, it's like a little bit like PTSD. Like,
Yeah.
you know, even with all these like strategies for dealing with this or that, you know, like I'm up at 3 o'clock in the morning with a baby who's maybe dying, you know, like there's no way around that, you know, like that's just a bad situation that you're managing, that you're handling, and you're watching the family suffer and you're watching the baby and you're like, you know, doing everything you can think of. And so I do worry about that toll, like watching all of that and going through that and then what that does to your own psyche and how you process it. So I try to have time to go through to kind of process the things mentally. I spend like a little bit of time alone processing and just reading or doing something solitary that like allows me to just really kind of zone in on clearing my head a little bit. And I feel like that helps. But it's not easy. It's really not easy.
So I know a lot of times, you know, people just think that doctors is at the bedside, but your job encompasses a lot, right? Teaching fellows, especially we had an educational hospital. So talk about some of the programs and things that you do that's besides patient care. Sure.
So I think the thing that takes up the most part of my time outside of clinical care that I'm most proud of and most passionate about is our fellowship training program. So I told you about after the med school, there's 3 years of pediatrics and another 3 years of fellowship. So I'm the program director for that 3 years of fellowship. And we have 7 fellows. We're expanding to 8 at our program.
Awesome.
So, you know, and I'm responsible for overseeing the training of those fellows for those 3 years to make sure that they're competent physicians by the time they graduate. So they're going to be ready to go and do what I do. And so, you know, there are a lot of clinical experiences that they have to have, that they need to go through and learn how to do. There are a lot of just like didactic or teaching sessions that we have to go through to make sure that they learn all the things that they need to learn. And then, you know, there are other things like research and administrative tasks that they need to learn how to do. That, you know, many of them will become researchers and have some component of researcher in their careers, and that's kind of what we hope that they'll add to the knowledge that we have to improve the care for babies. But it's a big program, and I don't do it alone. I have an assistant program director, and all the other attendings all contribute to these different areas. And we have, you know, we try to have as broad a curriculum as possible, like to cover all the areas, you know, like the lungs, the respiratory system, cardiovascular system, hormones, and endocrine system. Like we do like all those things. But then I also I also have an interest in ethics, like making sure that they learn like how to handle situations that might be challenging where, you know, things aren't clear what to do. And then, you know, a big issue, it's always been a big issue. Now it's more recognized, but healthcare disparities and racism in medicine is something that, you know, I think is extremely important to teach about and for them to learn about so that we can, you know, reduce those inequities. And I'm lucky as the program director to have the ability to, you know, to shape the program like the way in my own vision, you know, it matches like the way that the Board of Pediatrics wants it to be. I'm not like going rogue or anything, but you know, they also say that's important. That's in their content specifications. They say you got to teach about this, but I'm like, oh, we're teaching about that. You know, we're going to learn about that together, and it allows me to like I get the freedom to kind of like craft things the way I'd like to have a program crafted, like the kind of program I'd want to go to if I were going to train again. Not that I want to go through training again. Once is enough. But yeah, so I really like that. I'm proud of the fellows and all they achieve. It's graduation time, so we have a third-year fellow who's graduating. She's going to a great job. We're really proud of her.
Yes.
She's awesome. She's going to do great in the world, and she's going to make us proud when she says, "I'm an NYU grad."
Yeah.
That's amazing. Let's pull back a little bit. I don't know if you explained it yet. Did you talk about how you actually came to New York?
No, we didn't. I did not.
Let's hear it.
So as we last left, I was in Boston for 6
Okay.
years. And I had gone to college at Brandeis where I'd met my wife and we had dated in college, but then I went off to medical school. So we had broken up at the time and kind of stayed in touch. And so I was in residency, and one of my dear friends from college who happened to be in the room when I met my wife, he was living in the East Village and he bumped into her. And he called me and said, "Guess who I ran into?" So long story short, she's a New Yorker, right? So I made a deal with her, or she made a deal with me, or however you want to look at it. And the deal was she would come to Boston to live with me for the last 2 years of my training, because I was like at the end of my first year of fellowship. But I'd have to move to New York for the rest of my life. So
that's a sweet deal that she won.
I love New York, so I was like,
2 years for the rest of your life.
That's the exchange. Like 2 years, I will come to Boston. She's not a fan. And she's like, I will live there for 2 years, and then you come to New York forever.
Wow.
Like, okay.
Done deal.
Done deal.
Yeah.
So you're honoring it.
I'm honoring it. I have to say the last year has tested me.
Yeah.
New York has been tough. We live in Union Square, and it's been, with the pandemic and like all the things going on in the city, it's been tough. We've gone through it, and we've, I think thrived in some ways and suffered in others, but I'm a proud New Yorker. I love living here. I'm not going, even if I complain, I'm not going. I think that makes me more of a New Yorker. I complain about it.
Nice.
That's kind of awesome.
Love-hate relationship.
Yeah.
Exactly.
Unfortunately, we've been going through a lot in New York lately. And I hope it's coming to an end. I don't know. The weather's getting nicer, so pray for us.
I don't know what that means.
Yeah, pray for us. It's hot. A lot of people outside. But one of the things I wanted to get back into is talking about health disparities. And I was, I think it was last year, I seen like a poster. And I don't know who did the presentation, but they were doing a presentation specifically about African American women and them giving birth, right? Like as far as like this whole myth that obviously they don't feel more pain than other minority groups or people that are not of color. I just wanted you to talk a little bit about, you don't have to go in detail, just about things that I know our hospital or other hospitals are trying to do to educate society and making sure that residents and medical students are getting the proper education to understand that. I seen something like somebody was like, oh, they got to stop teaching people in med school that black people feel more pain, or like people are minorities. And I'm like, that's not how that goes, right? That is not a part of education. So I want you to kind of talk about how you guys are trying to bridge the gap, and, it's a whole systemic problem. It's not really a medical school problem.
Yeah, I mean, in some ways it is. Like there's something called the hidden curriculum as well, which is like what you're taught not from the books, what people say to you. And so, those myths exist. Like I heard that myth when I was at some point in my training.
Wow.
I don't want to impugn any part of my my training, but I heard that myth, and then I read and found out that it was BS, like totally not true. And so I took it upon myself to educate myself, to read a bunch of books, to read a bunch of papers, to really figure out like, well, what does it mean? And my wife and her family, they have a long history of like being like really activists and anti-racist and really, really very interesting family that I've learned a lot from. And so I really took it upon myself to like let's dispel these myths. Let's see what's real and what's not. And so I do have real strong feelings about how we strive for equity and justice in the system, and how we can make it fair for everybody who trains in it, who works within it, and then of course most importantly the patients that we take care of, because everybody should approach the system and be treated in a fair and equitable manner, right? And historically that's just not true. That's not the way the history of our country is. And so I ask myself the question, like, how can I impact that? How can I make that better? And the answer is like a lot. I have, I'm in charge of a training program. I can like design the curriculum. I'm, a doctor. I can choose like how to talk to people and how to like be with people and how to, how to practice medicine in an equitable manner. So our institution really has done what I think is a lot in order to kind of promote the education and promote equity amongst all of our patients and within our staff. We have a series, like a book series on like reading books that, and talking about racism in medicine. There's like a whole health equity series of talks that was given. And it's part of our curriculum in the fellowship training program. But, talk isn't enough, right? Like you got to also walk the walk, right? And so one thing that the hospital is doing is looking at dashboards and breaking down different outcomes by race to see like, hey, are we actually providing, is the care equitable? Are we like really, and if it's not, what can we do to fix that? So, are there more things we could do? Sure. Like, let's work on it. Like I'm open. And I want to have a workforce that reflects the patients that we take care of, and that is sensitive to their needs and that provides equitable care. NYU is not just this like fancy private hospital. We also care for patients at Bellevue, which is the kind of premier referral center for the whole public hospital center network in New York. And so, we have a real duty, I think, to provide equitable, non-biased care to the patients who come there. And they do serve, by nature, it being a public hospital, a very poor, predominantly Black and brown, many immigrants population. And so, how do we strive for social justice when people are like starting off like already at a disadvantage? It's not like even just getting to the hospital may be a challenge because it's far away from where you were referred to, and whatever other things are going in your life that make it challenging. So it is really hard, we witness a lot of inequities in the world, and healthcare shouldn't be one of them. I feel like everybody deserves good healthcare, and I would strive for that any day of the week.
I do have a question, though. You were talking about a lot of the things that you want to change. What are some of your goals overall in terms of maybe your future and also throughout the hospital?
So that's a good question. I kind of have a vision for care where families are really a part of it. There every day, participating in the care. Like I'm a huge proponent of what we call family-centered rounds. So that's where like when we do rounds where everybody gets together, reviews the events of the last 24 hours, makes a plan for the next day. And like typically that was done without the families even present, right? Like that was like the most important time of the day and they're not even there. So like that's crazy to me. Like, how could you make a plan for the patient without even talking? I mean, you catch them up later or whatever. But like, so having families there, if they want to be, like some people are overwhelmed, but if they want to be there, have them there for rounds, have them present. So like during the pandemic, it was like, oh my God, people can't even come to the hospital. People couldn't visit their babies. Yeah. So we're lucky enough to have an institute where we promote family-centered type care where I work. And so they sponsored a program that I helped lead that did virtual rounds. They gave us an iPad. We implemented a program. We're like, okay, parents are like here on the iPad, like they're there. And we call them and they would be there. And so that's kind of integrated into our care. Some parents like it, some don't. They want to, some people just do a phone. They don't want to be on camera like 8 o'clock in the morning. But, that's a way that we can like bring families, use technology, bring them into the unit, let them participate and be a part of the care. But just also like the NICU's open. You're the family. You should be here whenever. Like there's we don't have visiting hours in the NICU. Any hour is a visiting hour. Mm-hmm. I don't like it when we kick families out for any reason unless they don't want to be there. Sometimes that's too stressful. So, bending towards what is best for them. So like really like a vision of like families being at the center of what we do is something that I would like to not just have in neonatology, but spread throughout medicine. Like I have other encounters with the medical field with like, not necessarily where I'm the doctor, but I'm like on the other side, like family member or something. I'm like, that's how you're treating someone? Like, come on. Yeah. That's no good. So I think that throughout medicine, I'd love to see family-centered care. And then, we're talking about healthcare inequities, like we only can do so much in the hospital or in a clinic. If you see a doctor for like 30 minutes, right? Like there's only so much. There's all these other things in the world that lead someone to that point. And so, the education you get, the house you live in, the job you have, like the food you eat, the air you breathe, like all these things contribute to like your health outcomes, like in your wellness per se. And so, that's a lot to like take on. Like I can't change all that. I'm not a politician. I'm not an environmental engineer. Like I can't like those, I can control what I can control here, and I can advocate for what I think in the bigger world. And I just try to do the best I can in all those realms.
Yeah. So now in terms of your health, are you aiming for a 6-pack?
No, I gave up on that. I gave up on that. I was like, I like food too much. I try to be healthy, but no 6-pack for me. But I run every day. Keeps your brain clear. Keep you on the right track.
Awesome.
One of the initiatives I know that you're a big advocate for and that we do at NYU is Kangaroo Care.
Yeah.
Can you explain to the audience what Kangaroo Care means and why is it so important? Some of the research behind it.
Thank you. I'm a big proponent. So Kangaroo Care is when you put the baby skin to skin on one of the parents. So they undress the baby. If they have any clothes on, parents like usually wear some kind of clothing that they can open, button down shirt, and then you put your baby, you lean back, you put your baby right in your chest, and you put a blanket over and you just chill there. And this was actually first invented in, I believe, South America. So necessity is the mother of invention. We have incubators that keep the babies warm. They cost as much as like a car. So I think it was Colombia. I hope I don't get this wrong. But they didn't have a lot of incubators, and they're like, well, the mom is warm and they're there all the time. So they put the babies on the moms. It turns out they do as good or better. Like they calm down, their heart rates are calm, they have fewer like episodes of instability. They're just better. They grow better. So there's a lot of research that shows there's benefit to doing that. But in the modern ICU, we have plenty of incubators. That's not like a shortage. So we don't have a need to do that. But people look at that data and they're like, oh, maybe there are other benefits, like bonding, being close to your kid, family-centered care. So, at our hospital, we actually innovated and were like huge proponents and really brought a lot of Kangaroo Care to America. And with time, things like, new staff, this and that, like the numbers have kind of dropped, and we were like, hey, this is something we should really be doing. Yeah. So we put together a team, and we've been working really, really hard to do it. And for some of our patients, it's easier than others. Yeah. Like if you're breathing, you don't need any breathing support, and you're pretty big, preemie, you just have some like less acute or smaller problems, like you're learning to eat or something, but you're otherwise breathing okay, you can go to the chest, no problem. But we have patients who are ventilator dependent. They got a tube in their windpipe. They're like, the machine's breathing for them. If that tube comes out, that's like their lifeline. That's the only thing that's keeping them alive. But, so we're like, how can we, can we also Kangaroo Care those kids? And
that's when they scream, Paige Jonathan.
Yeah. We need Jonathan for this. And so, there have been some bumps in the road, and we're trying to do it. And we've finally gotten to the point where we have like a really good protocol, and, we've had some success. And it's been, imagine a parent who's never held their kid. Yeah. Ever. And you have like a 3-month-old. Never held their kid.
At first, I thought you guys was crazy. Yeah. And you guys start telling me to take kids with tubes in them and let the mother hold it, and everybody's staring at me, and I'm like, Yeah. But now, like, you really see the difference. Like, talking to the parents, and it's like, that was everything for me, Jonathan. I haven't held my baby 6 months. He's just been in the bed. Yeah. And even the babies, it's important. And it's just, once you have check and balances and a strong team behind it, anything can be done.
Teamwork, man. Teamwork.
Yeah.
Yeah, and like I said, like the whole separation. Somebody said this, that like separating from your parent is like the most traumatic thing a baby can go. Any mammal. Yeah. Like parents and babies are together. They breastfeed. They do that. Like they're always together, right? Like kangaroos are in the pouch. Like all the babies are like like that. So you separate them out of necessity. Like we got to save their life, help them breathe, give them fluid, do that, all these things, whatever. But then, we never put them back together. And Kangaroo Care is a way to put them back together. And so I think that's like a beautiful thing, and it's something that we've worked really hard to really raise the rates of it. We just showed the graph today at our meeting. I was like, look at that number. It's so cool. It's awesome. Yeah. So proud of our team and everything we're able to achieve. And, even the hardest cases, we're able to get them to do some Kangaroo Care. It's that really, that is I think the cure for some of that stress
Yeah.
that I feel other times, and helplessness when you're not able to fix the thing you want. You have a win, like a parent who's hadn't held their kid yet gets to, something like that. It really balances out the bad feelings.
Yeah, that's amazing.
Oh man, this has been great so far. We're not done, but we're gonna get me some more water and Gabe some more water, and we'll be right back. Thank you guys.
Are you looking for the best NFTs on the market? I'm talking about NFTs that even opera singers like me buy. You gotta check out Legendary Crypto Goat. You can find Legendary Crypto Goat on Rarible, OpenSea, and lazy.com/jconyers. Legendary Crypto Goat!
All right, we're back, but Kyrie had a great question off camera. We want to elaborate on it. So Kyrie, hit it.
Right. So I'm curious, when it comes to the mothers of the babies that you handle, how do they react to you doing your job? Do they like take in consideration your stress levels, or do they just bring whatever they're feeling to your table in that moment?
That's really good question, because we see an immense range of emotions, like anything you could imagine. I would say is like what we see. Anything from intense gratitude, like some people are like, oh my God, thank you so much for taking care of my child, and then other people, they get angry and don't know what to do with that, and you're the person in front of them, so sometimes the anger gets directed at you. And some people withdraw and don't say much and don't talk. There's like a lot of mood disorders or like depression type things that happen after delivery, even if everything doesn't, even if everything does go well. So we see this intense range of emotions that people are displaying or that they're experiencing, and then they're kind of sometimes projecting at you. And it's our job to kind of handle that, to accept it, to absorb it, or to like deflect, somehow like help them deal with that. And sometimes, we have a psychologist in the NICU who are like, that person really needs to see someone who they can talk to, like about the problems that they're having. Or, sometimes people, a lot of times they bring food and they're like, thank you so much. We can't accept personal gifts, but we're allowed to share stuff that's given. So like, people bring donuts or coffee or like cakes or whatever they think that like would make the staff, to show their appreciation. That's like a really, really beautiful thing. And sometimes it's the police, like every once in a while, it's like, oh man, we have to have safety.
Security!
Yeah, like every once in a while, it's like, we can't be threatened in our workplace. That's not okay. Like workplace violence is real. And so, sometimes, extremely rarely, unfortunately, that is the only option you have. We try, of course, never to do that, but it's like, we have a lot of training in de-escalation and to try to like make things like not get to that point. And as the team leader, that's like one of the things, like if there's a situation in NICU, I almost always will go to the situation and be the figurehead. The charge nurse, like the nursing person in charge, will also play that role. There's like a supervising nurse who's always in the hospital, who's above the charge nurse, who can come in. So we try to deal with those tough situations, and de-escalate. But really what we want is the families to like process their emotions, to experience them in like whatever way they are. Like, far be it for me to tell someone how to feel. I can set some boundaries on how you can act. Like that's, there's things that are definitely inappropriate. But, I try to make it a really wide latitude, like, because I know there's such a range of responses to what's happening, and it's so intense. People imbue their children and like it's the next generation, and this came from me. This is new life. This is like so important. This baby in front of you, of course they're going to feel strong emotions, and of course they're going to bring all their life experiences and everything they've been through to bear at that moment, right? They want the best for their kid, and they're going to get it. And how they're going to get it is ... Like, I don't know.
And,
right?
Just to piggyback off that, there's incidents where we may find out the kid have a genetic disease, and the mother or dad may find out that they have a disease they never knew about, or there's a time frame on their life, which... Obviously we can't say things in detail, but there are situations that happen in those type of issues. Or a mom who been trying to have a baby for a while, and this may be a third time, this may be a fourth time, and it's like, am I doing something wrong? Should I stop trying? But I really want a baby. So there's all different types of situations where, again, it's not just the child, it's also, the mother or dad who's suffering.
Yeah, we especially with genetic testing, like we have to be extraordinarily careful. New York State has special regulations about consent because of the risks of discovering things you may not want to know. Like one of the things that's in some ways a little funny is like one of the most common things that people discover is what we call non-paternity. Which is that the person who you're saying is the dad, that's not the dad. So a genetic test, if we get...
and dad wants to beat up me and Dr. Angert. We ain't do that.
We're going to warn you that one of the things we could find, so like some of these tests, you have to get DNA from the baby and both parents. And then, part of the disclosure in the consent form is, if it is, we could discover from this test that this is, that the father is not the father, if that's the case. So you decide whether you want us to do the test. The way we manage it is we, give them the option. Like you decide, we could not do the test. You have to sign the consent or not. So if you don't want the test done, we won't do it. But if we do it, we're going to tell you what we find. That's... awkward.
Seriously, it's like I really never want to work in a hospital.
That's hard. But disclosure helps. People kind of are like, maybe we won't do the test.
But something that may be obvious, but I just thought about randomly. Is there research that talks about? Is there a high incidence of like postpartum in mothers who have babies in the NICU?
Oh yeah, for sure.
Right?
There is a high degree of problems with mood disorders and other kinds of issues. And I think one of the other things I really want to bring up also is people who are in relationships really, really sometimes struggle after having a baby in the NICU. Some don't, but there's a much higher rate of couples separating or divorce or, other problems that were there before getting worse. And so, that's something that you really have to be aware of as the doctor, because, you're taking care of the whole family. If there's like some issue, like, you can see that parents disagree or they're fighting or they used to come together and now they're coming separate, whatever. Like that does happen and that's documented to be true. And that's just the stress of having a baby in the NICU. Yeah. You imagine you're going to have a baby, the kid's going to come home and you're going to do whatever you're going to do. But now all of a sudden, maybe it's life or death, or maybe it's adjusting to some new reality where the kid's not going to fit your perception of what they were going to be, and then you have to deal with that, and that can bring up a lot of conflict in relationships.
Quality of life is important to some people.
Absolutely. And so how are you going to deal with that? How are you going to adjust? And sometimes parents don't have the same vision of what things are going to be like, or they may make a different decision about what they're going to do, and then you have to reconcile that, because if a decision is binary, like yes or no, and they're two parents, they kind of have equal say. Yeah. So you got to figure that out, and so that's really tough to negotiate sometimes.
And I think a lot of things that people don't understand is that the world don't stop, right? Like if you find out that your child may have a disability or may have this certain type of lifestyle, still might have to work. You may think I have to work more. Dad may be there a lot by himself and he may resent mom. Mom may be there a lot by herself and it may cause resentment, but you never know what somebody's really going through, or like they're feeling like how I'm going to change my life. And you have, there's religious things we have to deal with. Mm-hmm. There is a whole huge umbrella of issues that we have to tackle. There are kids that are left behind and you have to call ACS and figure out how we're going to handle those situations. So it's just so much. And then like you, right? Life happens to you.
Right.
You may have to come in and smile and take on everybody else drama and stress and things that's going on. So it's not easy doing what you do. And we appreciate you, and we definitely need a lot more of you. So
I'm trying to make more with the fellowship. I'm doing my best, but
I don't know if they should watch it. They're gonna be like, yeah, I don't know.
That's too much. But I will say one thing that what you were saying made me think about, which is that our society does not provide a lot of support for what you're talking about, being there, being present, being able to be the parent that you want to be. Like you get 6-8 weeks of maternity or paternity leave if you're lucky, right? If you're lucky. And then when do you use that leave, right? Like do you use it when your baby's in the hospital? Maybe not, because maybe you need that time when the baby comes home. Who's going to care for the baby when the baby comes home, right? Like, our society doesn't say, oh, you're going through this terrible trauma. You need time off now to help and to be there and to like bond with your kid. And then kid's going to come home and you're going to need more time. No. You get like however many weeks you get and you use them or not. And then that's it. And, beyond just the work leave, there are so many other things that are like stressful, that are expensive, that cost, that are difficult, that people have to overcome. And in that period of like, you're expected to be pregnant and not having the baby yet, but now you have the baby and you're trying to figure out what to do. Like you said, life goes on. Yeah. And I see a family struggling with that, and we try to support them and try to do what we can, but a lot of it is like external, beyond our control.
Yeah, and half the battle is finances, right? Because you may have a kid who's there for a year, right? That whole time that medical bill is going up. Mm-hmm. Then Dr. Angert may make a decision and say this kid needs to go to a rehab facility, right? Mm-hmm. Then that's a whole nother situation you have to worry about, right? If a kid is trached, right? Yeah. We you may say, Jonathan, ENT, you have to watch them do 3 trach changes. Mm-hmm. That's something I got to go to school for 4 years. Mm-hmm. Then do training. You have to do 12 years, 10 years, right? And then we tell these people in 2 months, just do it 3 times and you can go. Right. Then Dr. Angert have to decide, okay, got to get them 24-hour nursing because they're not going to be able to survive and take care of this kid, a ventilator we have to put in their house. And then, we can't get nursing. We're going to get 8 hours because you're broke or insurance won't cover it. Like, it's so many like levels and things that you have to deal with. And a lot of it is society's fault. To be honest, a lot of it is capitalism. Mm-hmm. A lot of it is greed. And people don't realize that, the type of politicians and political and the type of kids we're raising affects every aspect of everything, from health, from death, from life, from, what type of society you want to be. And money clouds everybody's judgment.
Well, they say you can judge a society by how they treat their most vulnerable, right? And like if a newborn who's dependent on a ventilator, who's like been in the hospital for a year, isn't like one of the most vulnerable in society, I don't know who is, right? Like how does our society view that child and support that kid and that family? What do we do for them? Our reach kind of ends at discharge or transfer. Like, once the babies are ready to go home or go to like another facility, like a rehabilitation facility, then our job kind of ends. Like, we're no longer primarily in charge of their care. And like the next steps are like determined by these other entities, other doctors, other hospitals. And one thing we're really fortunate of, because we're an academic center, we have like a big ICU. A lot of places have this too, but ours is pretty special. We have a follow-up clinic. So ours is like long-standing and it's really good. So we have 2 developmental specialists, one who's an occupational therapist, another who's a psychologist, and then one of the NICU attendings, and then we usually have a fellow there too. And we see our patients at 6-month intervals until 2 years, the ones who are at the highest risk. And so we get to see them as they grow and then advocate for them and make sure that they're getting the services that they need and that all of their NICU type issues are dealt with, or anything that they encounter. Predominantly, it's for developmental issues to see, are they developing properly? Are they not? Are they getting the services that they need? Can we advocate for them? And the folks that work in that clinic are amazing. Like, if they see a baby who, isn't getting what they need, they'll pick up the phone and call the agency and be like, you need to give double the amount of PT that you're giving them. You know what I mean? Or we'll make a referral because, we noticed this. You should really see the eye doctor for whatever reason. So I said our reach kind of ends at discharge. We do have this clinic where we get to see the patients, but it's also another one of those times that is like balances out a good feeling that can balance out the bad. You're like, hey, that kid's thriving. That's awesome. Yeah. Like, we discharged them. I couldn't get that kid to eat, and now I can't stop him from eating. That's cool. That's a good feeling.
Going back to the idea of vulnerability, another pair of people that are vulnerable are new parents. As a doctor in that field, what would be your advice to new parents? How to raise the best kid, maybe.
Yeah. Well, I would say, from my perspective, it feels like parents are getting younger and younger every year, but it might be just me getting older. Now I look at new parents and I'm like, oh my gosh, like I didn't think I was that young when I had kids. And I'm like, oh my God, people having kids are young, like themselves, right? So like, you have to first realize that like, nobody knows what they're doing.
Yeah.
You know, you could read a million books, you can talk to everybody, but like nobody really knows, and every kid is different. And I think that keep your ears open. It's a learning experience. Take the wisdom of your elders, take the wisdom from books, take your wisdom that you gain from your own experiences with your own child, and then be accepting of who that kid is. Right? Because the kids are going to end up determining their own path in the long run. And you go from having maximal control at day 0 to having minimal control. Yeah. And that process is surprisingly difficult as a parent to give up that level of control. So I think that having a little bit of perspective, looking forward, realizing that okay, I can control a lot, but when am I going to give them their own autonomy? When are they ready to do this next step? You know, they're going to be able to walk on their own. They're going to be able to maybe even just be in a room alone. When does that happen? You know, you leave,
I'm laughing because I literally was talking to my brother. Is hilarious. My nephew is 1 week old, right? Born in Boston.
Nice. So medical care there.
And he's like, why does he only stay up to 5 hours? I want to sleep. And I was like, you have no control. You thought that you were going to control for the rest of your life. He's going to make decisions and you're going to think you have control, but it's always going to be some way around him. His interests, what he wants to do. He's like, I'm going to start working on fixing a sleeping schedule. I said, for a 1 week old, good luck. Tell me how that works. Yeah, but it's just so funny. People just, parents think you have control, but you don't.
No. And I think kids also have a sense of irony too. Because they're like, oh, you want to sleep those 5 hours? They somehow know how to mess with you just the right way, that you could not have even imagined, You really love baseball? No, they want to play football. Oh, no, it's not going to happen.
It's the ultimate test, I guess.
Yeah. Exactly.
Oh,
but patience.
Yeah.
Patience. Everything in life, from kids, just patience and dialogue.
Yeah.
I think nowadays, especially what's going on in our society, from a young age, we have to start having dialogue with our kids. We have to be understanding, try to speak their language, allow them to express themselves. There's a lot of bad stigma about mental health and speaking to people. I think all kids should do counseling. The world is different. Social media is different. They have access, especially if you're a New Yorker as a kid, right? You have to grow up fast.
Yep.
You have to, right? You're gonna be exposed to things that you may not see in Kentucky, right?
Yeah.
You may be in a suburban area where it doesn't matter how rich you are or how poor you are, we're on top of each other. Yeah. So you're going to see a homeless man and say, what's that? So, just patience and communication. And adults need it too. Adults need it too.
Yeah. And kids are in some ways really smart. They figure stuff out. They're like little learning machines. They may not have all the knowledge, but they are little critical thinkers. And if you give them the tools, they're going to figure out a lot on their own. And that process, I think, is really cool, is watching them figure stuff out on their own.
They grow really fast. So, Dr. Angert.
Yes.
We have a very important question.
Okay, I'm ready.
Kyrie has another question. Come on, Kyrie.
Right, 3 questions.
Bring it on.
All right.
Oh, Kyrie writing them down. We about to make you cover the camera. Luca, you got a question too?
I might have more than 3, but we can start. You said the NICU.
Yes.
For people at home, can you break down what the NICU is or what it means?
Sure. Excellent. I should have said so. It's an acronym, and it stands for Neonatal Intensive Care Unit. And it's an ICU, or an intensive care unit, that's specially designed for babies. So we generally take newborns, or we take transfers of kids who are preterm up to about a month or 2 after their birth date. So it's really, we don't take kids older than that. There's a different ICU called the pediatric ICU that takes the older kids. But any newborn who's born, or kid who's been in the hospital for a while who was preterm and is still within a month or 2 of their due date, we'll take them there. And it's highly specialized with lots of little tiny things. All of the things are miniaturized for these little babies. So, we have an immense range of sizes. The smallest baby we take care of might be 350 grams, which is less than a pound, right? It's like
some of them could fit in our hands. Yeah.
fit in the palm of your hands. And then we have like kids who are 5 kilos or 6 kilos. That's like 10, 12, 14 pounds. So that's the range of patients that we take care of. And all of our equipment, everything is like specialized. Like even the leads that we put on to measure their heart rates for the little ones is very specialized for their skin and to minimize injury. And everybody in there has special training to take care of these like fragile infants. And we work as teams. And that's one of the things I like about the NICU is that it's a real team effort. Like
Nice.
I could not do any of what is done in a NICU for a baby on my own, right? Like there are certain things I can do, but like the whole package of care that's delivered, like everything that happens, the respiratory care, the nursing care, the pharmacy, the therapists, the child life, social workers, like we all work together in order to, really nurse practitioners. Oh my God, I'm sure I'm leaving.
We have music therapy.
Yeah,
Yeah, people who come and literally just play the guitar.
Oh,
Leave the
that's
kids in the bed, but
It's so cool.
Yeah.
I love when I see the music therapy note. I'm like, when they're playing, I like.
I'll be in there like this.
I hang out when we're rounding. I'm like, let's stay in this patient for a little longer. So listen to music.
And we also even have something called the CCVCU,
Yeah.
which are very small babies who only have cardiac issues.
So really, really highly specialized care for newborns. And a lot of kids will be getting better. They're not quite as critical, but they'll still require hospitalization. So, we have patients that stay with us for months and months and months at a time. Other ICUs, their average length of stay, the number of days of patients there might be like 5 days. Like you get in there, you either get better or you don't, and then you go. For us, almost all of our patients get better, which is awesome. And then they don't go. They stay because they're still preterm. They're like maybe a couple months before their due date. They don't know how to eat. They have some breathing trouble. So we have patients that are with us for a long time, and we have what we call a step down unit where they get a lower level of care. They don't have ventilators, and they don't have other intensive types of care like intravenous therapies or other medications, and they can just kind of hang out there, learn to grow. It's a little more family friendly. There's more space. Parents can even sometimes stay longer with them, or even overnight. And then, then they grow and they get ready to go home. So we're a big major academic medical center, two really, between Bellevue and NYU. And then there are a whole host of other different types of neonatal ICUs all over the country. Some just take care of healthier babies, and others are like us and take care of basically anything that comes. And we take care of other hospitals, kind of unusual cases too. Like people refer babies to us as well.
Nice.
I have a few more questions. Some of them are trolling questions. Just to give you guys a, this is a trolling question right here, though.
Okay.
And thank you for answering that. You answered every avenue of that question. You compared it to other ICU care units, all that. You can cut this part out, but yeah, that was
no follow up. You don't need a follow up.
Basically, I should have just said that. No follow up needed. But are your hands insured?
No, but as part of I do get disability insurance through the medical center.
Yeah.
So my whole body is, thankfully. But
that's
not
a perk.
especially the hands, but my whole body is, thankfully.
Nice. And you spoke on society. They only have so many days outside of, getting care after a baby's born. So is it 4 to 6 weeks or 6 to 8 weeks, something like that? Outside of that, though, for you personally, what are your perks or non-work benefits that you get, from being a doctor?
Perks from being a physician.
I get high salary.
Well, I will say I'm not going to complain about.
Do they get half off at the grocery store once a week or something?
That would be nice.
They probably give more than that to us than.
We're not allowed to take any gifts.
Yeah.
I got a Starbucks card one time. I call a corporate. They were like, "Give it back." I'm like, "What? I'm gonna buy everyone coffee." No, give it back. They were like, so anyway. But I do have MD plates, which I think kind of cuts both ways. I think some cops are like, you think you're a doctor, get out of here. No, I don't know. I don't know if I get more or less tickets. I will say that I'm in academic medicine and not private practice. So that means I'm part of this giant group of doctors that does everything from infectious diseases to critical cardiac care to neonatal care at NYU. And our goal is to take care of patients, to train the next generation of physicians, and to do research, those three things. And only one of those earns money. Okay. And so what that means, I mean, sometimes you can get grants for doing, the other things, and the government does supplement also for paying for trainees, or, whatever. We do have resources, but academic physicians make significantly less than non-academics or those who are in private practice. So I'm not complaining about salary, but what you conjure in your head like might be a doctor's life is not necessarily what we live with. And also in pediatrics, there's a long history of also us getting paid less than other doctors. Why, you may ask? We care for kids. Yeah. You would think that society would say that's even more valuable than caring for adults, but that's not the way it works. And if you look at the published salaries, the average pediatrician salary is like considerably lower than almost any other specialty out there. And,
I always wonder why, but I don't even think there's an answer. We don't know. I think it's just perception. Do you think it's an answer?
I think that at least part of the answer, and you can push back on this if you think, but I think part of the answer is that pediatrics was one of the fields that had a lot of females, as did obstetrics and gynecology.
Wow.
And so a lot of the early pediatricians were women. And there's even to this day, and certainly historically, pay differential, like what someone's work is valued at. And even today, for surgeons, obstetricians get paid less than other types of surgeons, right? Pediatricians make less than adult medicine doctors. And, I don't know if that's the reason. I haven't done the research on that. But my suspicion is it might have something to do with sexism.
Wow, I never thought about that.
Yeah, that's big right there. Dang.
Yeah.
Oh, man.
Well-rounded yet again.
I feel like Luca got to ask a question. Kyrie, that's it. It's over.
He's gonna troll me. He's like,
Luca, you got to ask a question. Come on, Luca.
Well, going back to your experience, with the child that you lost, do you ever look at that experience as kind of like, I don't know the right way to word it, but almost like a superpower in your field, because you see these people and you've been in their place. Do you think, there's any silver lining perhaps from going through that?
I have thought about how it impacts my own choices in my career and my attitude and the way I treat other people. Recently, I think when I was younger, I just kind of like didn't think about it very much, but now I'm a little older and have time to reflect. And I do feel like it gives me a different perspective. Like I feel like I just having experienced that feeling and understanding that, I do feel like it gives me a different vantage point by which I can like look out and see a family and like maybe sense what's going on and try to work on fixing it or try to address the issue or try to design a project that's going to help all the families with that problem, like the virtual rounding. I do think that it definitely has impacted the way I think about these types of problems. And I do think that in some ways, I've talked about this with my wife too, like, well, was there any good that came from that? Like that horrible, traumatic, awful experience of losing a child. It's like the worst thing that most people can imagine. Certainly the worst thing I could have imagined. And believe me, as a neonatologist, I did imagine it. Like, it's the thing you think about because you're worried about, like, this is what I do. Like, we'd had conversations about, like, what ifs, I do. I never really reveal that to like patients because I don't want to make it about me, like it's about you and your life and your experience and your child. So like I almost never bring it up. There are people I work with. If they listen to this, it might be their first time ever hearing this story. It's not personal. I like you all. I'd be happy to share if you ever asked. But that said, it's like I don't want to ever make it about me. But I do think that like there is something that has like changed who I was and what I thought about what I do.
And the reason why I bring it up is because you said two things that I thought were really interesting because you said them like right next to each other. Was like you said, yeah, I can't really stay in there. I have 40 other people to attend to, but at the same time, you also said, but I can't leave them crying there by themselves. Like that feels like a crime to me, and that is I think you guys call that bedside manner. Is that something that is taught, or is that something that kind of comes more out of the doctor's personality?
It is something that we pay attention to in training. Like we evaluate and think about and talk to our trainees about their interactions with patients. So there's like, evaluations, we fill them out, and that is something that we look at.
Dr. Angert, I gotta disagree with you. That's 100% doctor's personality. There's doctors I see that has horrible bedside manner.
Yes.
There's respiratory therapists who have horrible bedside manner.
Yeah.
There's nurses that has horrible bedside manner, and it's based on your parents and your perspective on society and how you treat people. There are people who do things different than other people because of the color of their skin. And I'm not saying this is an NYU thing, please. It's not NYU. I'm just talking about in general.
Yeah.
Right? Dr. Angert is right? You could train about that, but you can't teach somebody how to be a good person because they went to medical school. It has to be in you. That's one of the reasons why I always gravitate towards you is because it's something that's innate. And it was my first time hearing that story, and it makes sense. And I think a lot of people, when they figure out I have a NICU kid, they see why I probably spend too much time talking to family members or hugging mothers because I know what it feels like. And there's certain things I don't know how it feels like. I don't know how it feels to lose a child. That's a whole different experience. But probably in 20% of certain things, I could talk to you about a little bit about this, So,
we try. We try. Like we do a lot of what we call simulation-based training, and we hire actors. We train them, their parents, and then we have scenarios where we're like, oh, you have to tell this person that their baby, whatever's going to happen, and then our trainees have to go into that room, just them and the actor, and there's a camera. We watch them, we record, and we have them deliver the bad news, right? And so one of the things we do is add error disclosure. Like, we made a mistake. I mean, it's not real. It's just like a scenario, but we want them to be ready to like be able to do that in the best way possible. And we teach them the curriculum, and we make them do that, and they practice, and then we give them feedback. Like, we sit down with them and be like, you did this well, you screwed this up, you did that well. And then the actor gives them feedback. And then we do that a couple of times throughout their training so that they can hopefully
that's kind of awesome, and that's the beauty about it, right? Because we all got so many different job functions that I didn't even know they do that, right? Because our simulation is different. Like, we have to go to Bellevue, and to me it's just all clinical, right? Because if anybody has to deliver news, that's part of Dr. Angert's job, like rarely, like, we don't have to tell anybody what's really going on or really speak much in a family meeting, right? But for us, it's more clinical. So that's kind of awesome. But that could also just be an NYU thing. NYU does a lot of amazing things that other hospitals don't do or have resources to do. So,
Well, we actually, NYU and Bellevue are both regional perinatal centers, which means like we act as information centers and also like oversight for a bunch of other hospitals. And so one of the things we actually did was the state also funds that. So we took some of that money and we ran that program for delivering bad news to our affiliate hospitals, and we had doctors from other sites and we had some of our own nurse practitioners and fellows all practice that. So we do try to like spread that, like to share with other hospitals that may not have the resource to do it themselves. And there are other hospitals that do that. I have to say I learned to do that at Montefiore, where I was there for a decade. And my good friend and collaborator there, Dr. Rosen, and I like worked on a lot of these, and she led a lot of those efforts. So I have to give her a lot of credit for being an incredible advocate for also that kind of family-centered care and paying attention to how people talk with parents and help them through these difficult situations.
Yeah. And I don't know. I think really, maybe I'm being biased because I work for NYU, but I don't think I've really ever seen it. But even when because my daughter was at NYP, all the bedside I don't know if it's a NICU thing. It's because you work with babies, so naturally you're just more of, I don't want to say, well, that's not fair to adult doctors. Like, I don't want to say you're naturally more caring. Like, I just feel like, I guess it's kind of a nurturer type of job because you're dealing with babies. So I feel like a lot of us is just more like, we work with babies. But I don't know. I've never really seen like really poor like bedside manners. Like,
well, the reason I bring up bedside manners, I'm a big fan of Malcolm Gladwell. One of his books, he talks about how there's actually a correlation between how bad a doctor's bedside manner is and how often they get sued. So it's like the worse or the better quality your bedside manner is, the less likely you are to be sued by your patients. Which, if you think about it, makes a lot of sense.
Yeah.
You don't want to sue someone that you like.
Guess what? We're not ending that thing. So one of the things I wanted to bring up, when you talk about family practice and I'm being involved, right? Now, at the end of the day, you expect a certain type of care, right? We cannot say that we're afraid to get sued, so the family shouldn't be involved. That's just ignorance, right?
Mm-hmm.
But do the hospital, right? Do hospitals, not NYU in general, like, do you feel like maybe they will put pressure or kind of take away? Like, I know we do a lot. Like, I've had parents come to me and was like, John, I seen the blood gas. What do you think about the pH? Right? And I'm like, how did you see the? And it was like, we have Epic. You know, like, there's things that we do that we let them know everything that's going on, right?
Yeah.
Do you think that make administrators maybe in the hospital system, like across the United States, like if that was something that was implemented like nationwide, would that increase, you think, people being sued or people using that as an advantage to get money out the hospital?
So I do think NYU is at the forefront of kind of putting patients first and transparency and the kind of care they give. Like, oh my God, if there's an error, we disclose it immediately. We don't like hide things from patients, and that's like never been part of the not never. Since I've been there, that's never been the practice. I think like years ago, like decades ago, yeah, there's a lot of shady stuff that happened, like in medicine. Like we all know that. There's like lots of books, but I can attest that like that being there, they're extremely concerned with providing transparent and honest and the best care possible. Like quality is the thing that they care about the most. Like that is it. At the end of the day, are you providing the best care? And what you're talking about actually is part of the law now. Like there's a law called the Cures Act, the 20th Century Cures Act, that says you cannot withhold data information from patients unless there's a compelling reason to do so. So there are some instances where you're allowed to do that, like if there's like a domestic violence situation and you're gonna like precipitate like somebody getting harmed, like then you can withhold that note or that data. And there's a little bit of delay for some things that are particularly sensitive to give the doctors a chance to reach out to the patients kind of proactively to tell them, you have, cancer. Not like that, like in a much better way, but like so that they don't read it on their phone and say, oh my God, I have cancer. Like to like give them a chance to like get that like good bad news delivery. So that kind of was mandated. Like we were doing some of it as an outpatient here and there, but like everyone does that. It has to happen. And I think that like, it's really about the rollout. Like, how are we going to do that? They just we prepared as best we could. They turned it on. And one day patients were like, what's this? My kid's x-ray says that. And you're like, what does that mean? Because like, there's all this doctor language. It's not really written for patients. And part of what they were trying to do was to kind of like push people to write stuff for patients in the reports so that like the patients can actually be partners in the care. And as somebody who's a big advocate for family-centered care, I'm like, cool. Like we shouldn't be afraid of anything we write in the chart being seen by the family. That's the record of what happened to their kid or to them, if it's them. And, and they should be able to read it, and it only benefits. And they've done a lot of studies on this and shows that it actually benefits the care because people like are, they have a visit with their doctor and they're told 5 different things and they like remember one of them. And then they go home and they're like, oh, I can just read it. It's like all there, like what they said. And that's actually a plus. Like, because sometimes you hear something, you're in shock and you don't can't process anything else, but then everything's right in front of you. You want to show your friend if you want to do it. I think that actually benefits people and it pushes us to be better doctors and better care providers. So I'm cool with that, although it wasn't easy.
But I feel like, again, right, being like, these people deserve the right to know what's going on with their body, right? And it's our responsibility to give you the best care we can. And if it puts pressure on some people who, may cut corners or you probably feel like you're not giving the best care, the fact that the person could see everything should make you want to work harder. But even if they didn't, you should be working hard regardless, because we're in a business where we can't cut corners. We have to be attentive to detail. And it's a very tough job because a choice you make, a choice I make, or a choice that you ask me to make can hurt somebody.
I see. And people are different. Some people never check. They're like, I don't want to know. I don't want to, I'll let the doctor process the information, tell me what the results are, and then we'll have a conversation. And that's the limit of what I want. And then some people want to know every number and see the graph and
Google it.
Print everything out and make a text, whatever.
Google, we're not going to get on that. That's a whole nother hour. Google's Dr. Angert worst nightmare.
Well, no, what I tell families is, I'm like, go ahead, look everything up. and then bring it to me. We'll talk about it.
I seen on Google that he's gonna explode if you give him more.
I was like, show me the link. Show me the link, and then let's talk. Because like, if you tell them to ignore that, then they're gonna distrust you. You know what I mean? Like they don't want to hear another side. Like, no, I want to hear the other side. I'll evaluate it. Like, there's a lot of stuff out there that's good on Google. You know, like there's a lot of hospitals that put out good information, and then there's like mountains of junk, you know, like BS and whatever that, or something that doesn't apply to you that you don't want. You know, it's like it's hard to interpret. I think that's like one of the things about the modern world is like there's tons of information. It used to be that there was like only a few people had the information, and you had to come to doctors to get the information, but like or go to their textbooks and try to, you know. And now it's like everyone's got the information. Yeah, it's all there. It's like, but what's really valuable? You know, it's like processing and understanding and knowing how to apply that and turn it into knowledge. And, you know, like that's the thing that makes, I think it's really important.
And I think that's what a lot of people don't understand is it's not just about knowing the knowledge, it's using it, right? Because you can know a lot of things, but you have to, you gotta know how to intubate, right? You gotta know how to put IV in, you gotta know how to do the pumps. In a way, we kind of engineer. It's like we talk about how the ventilator operate all the time to the fellows, and it's like, yeah, there's a piston in there, and when you hit this button, it goes off, and that's how you deliver breath. And it's like, well, how would you know that? Well, physics.
Yeah.
Part of pre-med is physics. We have to do certain classes to understand like how things work.
Exactly.
So it's cool. But this is an educational pod. So Kyrie, what's up? You guys got any more questions?
Yeah. So I mean,
educational, not messy.
Of course. You kind of went into it as you did earlier. So it sounds like you do support medical apps in terms of like diagnosis, but do you support like the therapy apps or like, you know, like the hotlines and stuff like that? Do you think those are like helpful or more harmful?
I'm a big fan of technology. Like I love leveraging technology to do cool things. And I think that, you know, anything that makes healthcare more accessible but remains high quality is potentially good. You know, like I think that there's lots of good that can be had looking at your phone or having a remote therapy session or, you know, this or that. I think there's like informationally, I use apps all the time. Like our
my follow-up question, do you have any recommendations medical apps or therapy apps that, you know? I don't
none that you invested in.
I don't have any financial interest in anything. I mean, I use apps that are really geared to doctors. They're like lists of drugs and medications and doses for preemies, and you know, there are certain ones that are behind a paywall that have like medical information that like the hospital pays for that I use. There's some apps that are like very specific for certain things I use for teaching, like, oh, I want to show you this image or video, it's on this, like those are things. But in terms of like family facing, I don't like it's very specialized. So there are like particular websites, like I would point you to, like if you had a kid who had a particular problem, I was like, oh, there's a society just for that of parents who are all, you know, share information and you can like get, you know, this and that. So it's like, oh, go to this website, you know, for like this particular problem. There is a lot of support for prematurity. I will say that March of Dimes has a huge push towards treating kids who are premature and supporting families of preterm babies. And I mean, their mission is birth defects, and they look at prematurity as like itself kind of a birth defect. Like it's not like you're born early and you're sick. So I think like the March of Dimes has an enormous amount of support for parents of preterm kids, and they support a lot of research about prematurity. So I'm a big fan of that, and I march every year. Didn't this year, but every other year I've marched with the March of Dimes, and I think they're that's an organization that I would endorse.
Breastfeeding too.
Yeah,
I've been sending a lot of links out to people, especially what's going on with the shortage right now about breastfeeding. There's a lot of great Facebook groups out there for mothers who are experimenting, because sometimes, you know, it's about experience, right? Like there's things that me and Dr. Angert can't talk about when it comes to a female body or you know, breastfeeding a baby. So, you know, even in certain positions, you have to shift that over to other people.
Yeah. I'm not a medical expert, but I would say a good app is that Calm app. This is not sponsored, by the way. If you want to, definitely sponsor us. Calm is great, you know. Definitely takes some time to like
we
think
do that
about
sometimes
your
for the babies.
Really?
Yeah, like
That's
we play
awesome.
music or like what is
that
it called?
leads into my next question. You guys
Or-
are amazing.
No more questions for you, man. Dr. Angert got babies to save, man.
I like relaxation apps too.
Yeah.
I got a sleep app.
My last question: what is the best way to stop a baby from crying with or without the mother there? I'm sure you had the answer to this.
Well, as a big proponent of Kangaroo Care, I think generally you have to try different things because they can't talk. So like you have to figure out what's going on. Sometimes if they need to be held. Not always, but sometimes. Sometimes they have a poopy diaper. Sometimes they're hungry. Sometimes, like they're just crying. It's like that's the time of the day. So like I would say try the things that help your baby.
Yeah.
But like the best one is holding the kid. So I would go to that one first. So yeah.
I don't have any babies, but I do have 2 dogs, and it works always.
Dogs are kids, man.
They never really grow up, but they stay in like a great age. They're like always kind of like a cute little happy kid you got around.
Yeah.
Definitely.
A lot of work.
I love my dog.
All right, Dr. Angert. Number 1 question.
Yep.
What is a professional winner to you?
Aha. I think somebody who is able to live their values in their daily life and to like live their life as an expression of what they believe in, to do good in the world, to have a positive impact, and then to do something that you're proud of and that you enjoy doing and that doesn't harm anyone and helps.
Thank you. This has been great. We appreciate you all for tuning in. If you want to see part 2 with Dr. Angert and Kyrie, you can do it on our Patreon. Click the link somewhere. Luca put it somewhere. But thank you, Dr. Angert. You're great. Keep doing what you're doing, and I hope a lot of kids watch this. We need more doctors. We need more politicians. We got to create systemic change, and it starts with people like you. Thank you so much.
Thank you. And it's such a pleasure working with you every day. And then thank you for inviting me on the podcast. I've really enjoyed it. I love podcasts. This is like a particularly cool thing to actually be on the other side of the mic.
So awesome. Subscribe, watch all the videos, and download this because this was great.
All right.